Hi guys, so preponed ENT thoda bahut, but I hope you guys can hear me. Before we continue with the rest, I think ये बोलना ज़रूरी है कि this time I think a lot of you found this time's exam a bit challenging, but technically knowledge-wise it is not a very difficult exam. Yeah, the presentation of the questions have been with a lot of clinical images, radiology images which you may not have been used to see or may not be available in your books or notes, and there will be clinical application questions that were asked, and I have been incorporating this in my teaching for the last 1.5 years, showing as many clinical, as many radiological images, as many clinical scenarios. But scenarios can be indefinite. Patient can come with any presentation and examiner can design a question with any presentation. So fundamentals आपके clear होने चाहिए and you will be able to solve these questions fairly easily. And I'm going to just show you with an example over here with the questions answering that fundamentals are all that were asked this time. But if you have any questions or doubts, you can just put it in the comment section over here. So guys, these are just first cut questions. Options may not be accurate, so we will just take it from there. Okay, so paper 2, which was assumed to be more difficult than paper 1, this particular image or something similar to this was asked, and they were asked, and you were asked what was the surgery or the procedure. Now even if you have not seen this procedure, you don't know the name of this incision, tab bhi answer of exclusion and thoda sa clinical application say you can address this particular answer very easily. See, look at these, the incision is outside. See, whenever any external incision is made on the nose, obviously an external correction has to be done of the external part of the nose. Agar septoplasty या submucosal resection या FES, all of these are internal procedures. We don't have any external excision. They are all submucosal excisions. So in this, it is open rhinoplasty, which is fairly straightforward, even if you don't know answer of exclusions. Okay. Submucosal resection is inside, deeper incision, Freer's incision. FES is got no incision. Cadbuloc procedure is got an incision over here inside the lip, which is a very outdated procedure. So this is open rhinoplasty, no confusion, very straightforward. This also, yeah, so many times this has been asked, tod madod ke in your PYQs and many times, okay, where you see a Carahart's notch, which is a 2K frequency, mein you see a bone conduction dip. This is called as a Carahart's notch. This has been asked, so many times. So whether they asked whether the diagnosis was otosclerosis or whether they asked what was the clinical sign seen, in either ways it is a otosclerosis, very straightforward over here. And you can see that the dip is in the bone conduction component. If both the bone and air conduction, if both of them dip at 4K, then that is noise induced hearing loss. Okay, that is when it will be noise induced hearing loss. Ototoxicity will be like a sloping hearing loss, and in Meniere's you will see an upward curving pure tone audiometry. So it was on clinical sign, Schwartz sign. Okay, so you guys are saying Schwartz sign. See guys, technically let me tell you, if they gave Schwartz sign as the option, then technically it is not a correct option. See, Schwartz sign is an early stage where there is otospongiosis seen only in 25% of the patients, where the Schwartz sign will be seen, and that time that much conductive deafness will not be there. But still, understanding that the examiner attempted to connect you in a little indirect way, unhone Schwartz sign de diya, so then Schwartz sign would be the answer, which is the flamingo pink appearance in the posterior superior quadrant of the Schwartz sign. Okay, so we will just go with that. Hennebert nahi Kailash. Hennebert is not there. Hennebert is seen in acoustic neuroma, where you lose it's a fistula sign is the Hennebert sign. वो Hitzelberger है. So signs were asked, and I think other options they must have given Hennebert's or Hitzelberger, whatever. But this is Schwartz sign that would be related, so no issues over there. I don't know whether this question was asked. Some students have shared this with me, which papillae of the tongue do not carry any taste sensation. ये पिछली बार भी आ चुका है, INI-CT में भी आ चुका है, and piliform papillae is a very straightforward, where this do not carry taste sensation. Okay, so I don't know if this was asked, not in second paper. So then let us move ahead. This was asked, right? Head impulse test, HIT, head impulse test was asked, correct? So here is a patient with vestibular neuronitis, which is peripheral vertigo. There is central vertigo because of the cerebellum, and then there is peripheral vertigo because of your hearing and balance mechanism. So here the head impulse test will be in what is the sign. So some people are saying that this question was not asked in second, but this was not covered in the first paper. So let me just answer here. Your vestibulo-ocular reflex will be when his head is turned to right, your eyeball moves to left. Okay, so it is when you ask the person to fix the eye and you suddenly turn the head, the eye will remain in the middle, but it will give a nystagmus in the opposite direction. Head turns to right, eye moves to left. Okay, then this glomus tympanicum and glomus jugulae was asked in second paper. A patient with conductive hearing loss and pulsatile tinnitus. What was the diagnosis over here? Was it asked? There's some confusion in this question. A lot of students have written to me. I don't know whether a CT scan with the glomus tumor was shown, and many of you are answering glomus tympanicum over here. But here this. So what was the CT scan like? Did it show a big jugular area? The tumor was there, because glomus tympanicum is a much smaller tumor. If it is masked behind tympanic membrane, it will be bold. Over the promontory bol diya tha. If it is over the promontory, also it was told. See guys, I am just giving you an answer just from a clinical standpoint. I will validate the question again. But if the word pulsatile tinnitus was given, pulsatile tinnitus is more classical in glomus jugulaire more than glomus tympanicum, because the glomus jugulaire comes from the hypotympanum. It is much closer to the internal carotid artery, whereas the promontory is your medial wall, and in the medial wall from the promontory, those nerve plexus are much smaller. Those vessels that are there, that plexus is much smaller, doesn't produce a very large tumor, and there are only very few studies that show glomus tympanicum cause pulsatile tinnitus. All right. So in this case, so somebody is saying Phelps sign. So Phelps sign is seen in glomus jugulaire. I would currently lean towards glomus jugulaire as the answer given the current information. We will be doing a more formal recall where we will get more validated questions and the options, and we will provide it. But from the information that I am having right now with a CT scan like this and pulsatile tinnitus, conductive hearing loss, then it would be glomus jugulaire. Both of them will cover the mass of the promontory, because middle ear is a very small area. Okay, so glomus jugulaire comes and it grows up, and it is much closer to the anterior wall, which is the internal carotid artery. So you will be able to get this. Both will have mass behind tympanic membrane, Farhan. Both glomus jugulaire and glomus tympanicum will be a mass. Rising sun sign is seen in glomus jugulaire. Glomus tympanicum is slightly more superior and posterior. This was asked something like this: a patient with prolonged intubation, what is the staging used for this particular condition? This is a subglottic stenosis, I think. Okay, and any intubation more than 6 days. Okay, so if somebody has a prolonged intubation which is considered for more than 6 days, they can develop a subglottic stenosis, which is a chronic complication. After many months or few months, not immediate, there will be fibrosis, and this patient will come with this kind of a narrowing in the subglottic area. Of course, it cannot, Aman, I will have no idea what the exact image was. I didn't give the exam and nobody shared, but we are getting representative images and we are sharing it. Whether it was a clinical image or whether it was a X-ray showing narrowing, the thing what they're trying to say is that it is subglottic stenosis, and Cotton-Mayer's classification, where there are 4 grades, okay, and which is basically saying 0 to 50% is first grade, 50 to 70% is second grade, and 71 to 99% is third, and complete blockage is fourth. All right, so but it looks like this image. All right, so then this would be Cotton-Mayer classification. Others are for cancers and juvenile nasopharyngeal angiofibroma. All right, Then there was this other question with chronic obstruction. 3 months ago, patient undergo some sort of a surgery. There is crusting and septal perforation. I don't know endoscopy image दिखाया आपको या आपको ऐसा image दिखाया, but some septal perforation image was shown. And if that was shown, then what is the procedure? Okay, I don't know the exact option. Some people said turbinate reduction was there. Some people said FES. Some people said Cadwell loop. But the only option which I heard consistently where we will see this kind of a complication is in submucosal resection, which is removing the bone and removing the cartilage, and many times there is we don't get the plane very well, and there will be a through and through perforation either immediate post-op or after some time. Also certain infections can cause Denker's surgery will not cause this kind of a septal perforation. So in this case it would be a submucosal resection surgery. All right, then there were questions of paper 1 which we have already covered yesterday, though there are some questions from paper 1 discussed over here today. Maybe some questions of paper 2 were there. Students are just randomly sharing and we are putting everything across. Overall, I think it was not too difficult, but thoda sa clinical presence they are doing, and this is going to be the trend. And if you look at the teaching methodology that I have adopted in PW MedEd is completely to show you clinical images, as much as possible clinical application, and train you with basic fundamentals. So hope to continue doing that. But with that, guys, all the best, and you can now follow the next faculty. I think Dr. Santosh is probably ready with his medicine answer. Signing out, Jagadish Chaturvedi. Bye bye.